And welcome, Dr. George. We're so pleased to have you back. Um, for anyone who is new, welcome also. And I'll just take a moment to share with you that Dr. George is one of our neonatologists extraordinaire, as well as having so many other hats, including incredible leadership in establishing and developing neonatal palliative care programs here at Kapiolani, which serve the patients and families of the entire state. Because as you guys know, we're the only sort of advanced care NICU that's here in Hawaii. So I'm going to let Dr. George go ahead. As usual, I'll be kind of checking in with the chat. And if there's any kind of clarifying questions or something right in the moment, I might interrupt. Otherwise, we'll have a little bit of time for some questions at the end. And go ahead, Dr. George. Thank you so much.
Hi, thank you, Dr. Maxim. Thank you, Summer. I'm just really, really honored and excited to be here today. Please interrupt at any time to ask questions. This is more of, I really want it to be more of a dialogue. And I got a suggestion from a very wise person, Dr. Luca, to try to give it in more of cases so that it's more relatable. All right. So I am here to present about pediatric palliative care. These slides are shared by myself and Dr. Jasmine Jensen. So I just want to give her also honorable mention today. Next slide, please. I want to say I have no relevant financial relationships or conflicts of interest to disclose. And my objectives, I really want when we finish this discussion or dialogue that you're able to describe the perinatal and pediatric palliative care services that Kapiolani Medical Center for Women and Children offer, to understand the different facets of what family-centered goals of care discussions entail, to identify patients who would benefit from a perinatal or pediatric palliative care consultation, and to truly understand the importance of community partnership in caring for palliative care patients. And I'm calling you guys out as being that larger community to really take care and own our patients in the state of Hawaii. Next slide, please. So Kapiolani's palliative care service delivers holistic, compassionate, and individualized care. We aim to improve the quality of life of patients and families facing serious illness. We want to optimize pain and symptom management. We want to enhance partnership between patients, their families, and all of the medical specialists across the state of Hawaii. We want to provide comprehensive bereavement care to our families, and not only our families, but also our staff. We sometimes forget that we're also an important part of this care. Next slide, please. So our program design and integration into our hospital. I'm just going to give you a little bit about what each service entails. So palliative care, what we aim to do for Kapiolani and for our state is we provide person-centered holistic care for those living with serious illness. We want that care to be appropriate for all ages and disease stages, even in the context of prognostic uncertainty. We want to provide, along with curative or life-sustaining treatments, care through hospice enrollment and end-of-life care, and into caregivers' grief and bereavement. And what that simply is saying is just because you're a palliative care patient doesn't mean that you don't continue to receive curative care and life-prolonging treatments. There's a specialty of palliative care called perinatal palliative care. And it's a hot topic. It's gotten a lot of traction over the last decade or so. And what it is a family-centered care model for fetuses or newborns with a life-limiting or life-threatening illness. It begins at the time of diagnosis, continues through delivery and the immediate neonatal period, and is provided alongside curative or life-prolonging treatments and extends into bereavement. So what I want you to think about is a mom, a woman in our community. She has finally gotten pregnant. Her and her partner have been trying. They go to the obstetrician for her anatomy scan. They've been so excited. They go to the obstetrician for her anatomy scan at 18 weeks, and they could already tell in the room something is wrong. Us as healthcare providers, we think that we have the best poker faces. Actually, we suck. We are the worst at it, right? So the ultrasound tech is in there doing the ultrasound, and they're trying to keep a straight face because they know something just doesn't look normal. And this couple could already tell something is wrong. When they inquire, the ultrasound tech says, you know what? I'm going to bring the doctor in. And the doctor comes in and delivers the news that their precious bundle of joy is not normal. Something's wrong. And from 18 weeks of pregnancy until delivery, that couple, along with the family and their support system, lives a life of uncertainty, devastation, and grief. Next slide, please. So I have a question for everybody. What percentage of women who choose to continue their pregnancy knowing their fetus has been diagnosed with a life-limiting condition did not regret their decision to do so after the birth of their child? I don't like to call people out, so I would love, so someone said, "Ooh, we're getting answers." I got D, C, B, C, D, C. Okay, so we have a lot of C's so far. The C's and the D's are going neck and neck. Anybody else? Just throw it into the chat. I just have a last C. Okay, I got C's. I got another D. I'm thinking the C's are taking a little bit of predominance. Go ahead. Anybody else? Just put your thoughts in. There's it's just curious. I thought this question very interesting, and I actually didn't get it right the first time. All right. Anybody wants to answer after Mary? Okay. All right. So we have a preponderance of C, but D is close in the race. So let's see. Next slide. And the answer is D. 97% of women who choose to continue their pregnancy knowing their fetus has been diagnosed with a life-limiting condition like trisomy 13, trisomy 18, did not regret their decision to have their child. Next slide, please. So I'm going to present two cases. These case studies are a de-identified amalgamation of the experiences of several of our families. Some images are used with the family's permission, while others are just stock images from the internet. Okay. Case 1. Anna and Jay are parents of 2 expecting their 3rd child. At 18 weeks, they learned that their baby girl has trisomy 18. And this is confirmed with amniocentesis, and they meet with a genetic counselor who tells them that this is a life-limiting condition. Anna and Jay went home after this devastating diagnosis, and they considered their options, one of which was termination of the pregnancy. Ultimately, they decided to continue the pregnancy. And this decision aligned with their spiritual and personal beliefs and values. As baby continues to grow and there are multiple ultrasounds done, there are multiple anomalies noted. and they go for a fetal echo, and the ultrasound of the heart does not look good. So they refer to a cardiologist. And they learn from the cardiologist that with her heart defect, it means that their daughter will likely not be a good candidate for cardiac surgery. And even if it is that we can find a surgeon in the US who is willing to operate, it will require transfer to the mainland. It cannot be done here at Capulani. Anna and Jay asked about an option to focus on just comfort for when their child is born. And as such, a referral to the palliative care neonatologist is placed. Next slide, please. So what's our scope of practice? When we talk about life-limiting or lethal conditions that could be identified during very early in pregnancy, we know the gamut of trisomy 13 and 18. We have the lethal forms of osteogenesis imperfecta. What we actually do see a lot of in Hawaii, actually, is a lot of severe brain injury. We see a lot of encephalomalacia, a lot of severe congenital hydrocephalus, and many more, including within the last month, I kid you not, we've had 2 bilateral renal agenesis. Next slide, please. So what do we do? Well, referrals could be placed by anyone. Say it is that you're a pediatrician or you're a physician who is seeing, that's a pediatrician who's seeing like one of your patients in the clinic, and the mom is pregnant. And she tells you that, you know what, my baby is we didn't get good news on this pregnancy, baby, because you congratulate her, right? When we see a person pregnant, we say, oh, congratulations. And then they pour this out at you because you're somebody that they trust, right? And they may offload on you. So you could actually place the referral. Anyone can. The obstetrician can, the MFM can, a genetic counselor can, anyone can place a referral to the palliative care group to be able to see this family. Okay? Even the family themselves. Ideally, what we like is that the family has already been counseled regarding their options, whether they want to pursue terminations, if that's within their belief system, or whether they want to continue the pregnancy. They should have already made that decision. They should have already met with some specialists, like the cardiologist, if there's a cardiac anomaly, to tell them what would be the ultimate outcome, even with surgery. But not all the time this happens. So we see them anyway, and we help coordinate their care. But by the time we meet with them, what we want to do is have some real goals of care discussions that are individualized to that family. Next slide, please. So Anna and Jay met with us. They understood they had a good understanding of their child's condition. And sometimes we think that parents don't get it. When they ask for more information, we're like, oh, this family just doesn't get it. But actually, most times they do get it. So when we asked Jay and Anna what they understood about their child's condition, they were able to tell us everything about trisomy 18, sometimes even better than what we know or remember from med school. And they were able to tell us what their goals for their daughter was, because that's what we asked. What do you want for her when she's born? They told us they understand that Dana, their daughter, might not survive pregnancy. She might not survive delivery. And if born, she likely wouldn't survive for more than a few weeks, if they're lucky. The decision was made for comfort-focused care at the time of birth because they expressed that they were hopeful to meet her. They didn't want her to suffer. And if she could breathe well on her own and was otherwise stable, they wanted to take her home with hospice. The family requested assistance with explaining Dana's condition to their young siblings, and we have that service right here at Capulani, and that's our child life specialist. And sometimes families don't really want other people talking to their children, and that's okay. That may be a cultural thing. But the child life specialists, what they did is they spoke to Jay and Anna and told them, gave them some tips as to what to tell their two other kids at home. And I will tell you, I've been in a situation where I was in a room in the NICU and a baby was passing. The parents had chosen, they had done everything for this 23-weeker. And, she had reached the point where we just were starting to do things to her than for her. And they decided to take the breathing tube out. And we had the whole family in the room, including the 5-year-old sibling. And the 5-year-old sibling was holding baby. And mom said, yeah, your sister is now an angel. And the 5-year-old looked up at her mommy and said, Mommy, where are her wings? And then the mama looked over at me and I said, oh, no, I don't know where we go from here. Like, I don't know where we come back from here, but I try to assist as best as I can, but always knowing and kind of maybe encouraging families who are going through this to really reach out to Child Life, because they may offer tips that they didn't even think when you're dealing with an abstract thinker, with a concrete thinker rather than an abstract thinker, as we know children can be at certain ages. Next slide, please. So when we have these goals of care discussion, what we do is we try to figure out what are the family's prognosis, like what do they understand about the prognosis? And things to be able that you can ask to be able to kind of tease this out with the family is simply questions as, what are you hoping for? What are you worried about? We try to elicit the family's understanding of potential disease trajectory and outcomes, their understanding of the treatment options that are out there, and the implications of what these choices are on outcomes. Meaning, if I go to Stanford and I have the cardiac surgery, how much time does that buy me? What's the chance of her dying on the table? We try to find out the family's beliefs, their values, and their views of what quality of life is. I will tell you, everybody in this room of 23 of us have a different idea of what quality of life is. And I love a paper that is entitled Pepperoni Pizza and Sex. And what it is, it's a neonatologist writing about her experience with a family. That family, it was a 27-weeker Down syndrome baby in the NICU and was doing okay until not, as we know for anybody who's ever rotated in the NICU. And she was having a conversation about how the baby was doing. And the mom asked, would we be able to love him? The dad asked, would he be able to love us? The dad also asked, would he be able to have sex? Because to him, a good quality of life incorporated those things. And then the strangest question, if that wasn't strange enough, was would he be able to put pepperoni on a pizza? And what it was is that that family was part of a family that owned a pizza parlor. And everybody would help out in the pizza parlor, preparing pizzas for customers. And there was already a child in the family who had a disability. And all that child used to be able to do was put pepperoni on a pizza. And that child was so happy. So to that family, if their son was able to put pepperoni on a pizza, have sex, know how to be loved, and know how to love, that for them was a good quality of life. We also try to get from families how the family envisions spending whatever time they have with their child, How do they envision doing so? Do they want to spend it in a hospital where there's a safety net? Or do they want to spend it at home where they could be surrounded by everyone who loves them and supports them? Next slide, please. So Dana was born at term and her delivery was uncomplicated. She was able to take breaths on her own and was quiet and alert. She was held skin to skin, and she was actually able to latch and briefly suckle on her mother's breast. She was held by her parents and her grandparents, and after about 30 minutes, she developed some increased work of breathing. Her nurse gently suctioned her upper airway and helped her parents reposition her. Over time, her respirations became slower and further apart. And her nurse let the family know that her time with us may be short. Dana died peacefully, surrounded by those who loved her the most. It is very hard. I went to an LNEC conference once, and I loved when the speaker said, it's very hard to say hello and goodbye at the same time. Next slide, please. So when we talk about comfort-focused care, it's supposed to be personalized. We want to avoid interventions that would cause pain, that would be invasive, and would really worsen any quality of life. We want the goal to not be to prolong or to shorten life, but to make whatever life that baby has, whatever time we have with the child, a meaningful one. We want to weigh any interventions really carefully. The benefits of that intervention versus the burdens. And we want to make sure, right back around, that it is unique to every family who we take care of. Next slide, please. So when we talk about pediatric palliative care, I want you guys to know that in the US, 500,000 children experience a life-limiting illness every year, as per our 2015 statistics. About 50,000 pediatric deaths occur every year. At least 20% of children who die receive palliative care services. Why? Why only 20%? And less than 10% get hospice services. So what does that translate to? 80% of our patients, our pediatric patients, die in some acute care setting instead of at home with their family. Next slide, please. So there's some trends in pediatric palliative care. We know that children with serious illness and complex healthcare needs are living longer. Now, are we doing anything different? I don't think so, and I'm open to anybody's ideas. I think, what we are doing is we're just diagnosing them earlier. And so therefore, we're treating them earlier. We're diagnosing in the womb or before these children are born, for most cases. Children with serious illness who could benefit from a pediatric palliative care consultation continue to increase. The children that could benefit from it. What all the literature shows us is that early involvement of palliative care allows for rapport building and the ability to establish family-driven, value-based care. To grow, it is essential to include all settings where children receive care. And this is a picture of one of ours. Next slide, please. So palliative care in the region in our region, we're growing and we're expanding to meet the needs of our patients, our families, and our communities. When I first got here 8 years ago, I was told that we could not do comfort-focused care from the delivery room, as in the case of Anna and Dina, and Jay and Dina. Every patient that was born in Kapiolani, every child, every neonate that was born with any life-limiting condition had to go to the NICU first. And then they will stay in the NICU. And if mommy had a C-section, well, tough luck for her. But you know, one thing about women and mamas, they will tough it out. And I remember somebody very dear to us who had a baby and her baby was in the NICU, had actually peritonitis, but was still in the NICU trying to see her baby. So every baby came to the NICU and the moms just had to follow suit and come whenever they were cleared. Worst case scenario, that they were on magnesium and couldn't move for more than 24 hours. We have since changed that. And with a lot of support from leadership, but mainly our nurses, we are now able to keep the mother-infant dyad together. So any baby born or referred to us from any other hospital in the region, they come to the labor and delivery, and that baby, when born, stays with mom until stays with mom and dad and family until his or her last breath. And we do not put the babies on mother baby, well baby nursery, because I think that seeing everybody celebrating their baby's birth and you are struggling to say hello and goodbye is not okay. So they're moved to the med-surg unit after recovery in L&D so that they could truly enjoy that meaningful time with their child as much as possible. I will tell you that's one dream that we've had, but we have another dream as the palliative care team at Kapiolani. And that is to be able to do that for every patient in the state. And yes, I am talking about our outer island families. Why is it that when it is that they have a child with a life-limiting condition, they have to leave every bit of their support system to come to Kapiolani, have a new set of doctors, new set of nurses, go through the same thing, have to answer the same questions over and over, and not have their baby surrounded by the people who love that baby the most? Well, change comes with hiccups. So last year, at around this time, we had a mama in Kona, and her baby's name was Violet. And that mama had 8 other children. This was going to be her 9th. She was no longer with the abusive father of her children, physically and verbally abusive. And you know what? Her one support system, her own mother, had died in February of last year. So she had no one. And she called her 9 kids at home her angels. And she said, Dr. George, is there any way that I could have my angel with trisomy 18 meet my other angels? And I said, I don't know, but we are going to, you know what? This has been a dream of us and we are going to make it happen. So around this time last year, we decided, I consulted her in March. We decided that we were going to try. I got permission from the pediatrician in Kona to see if we can try. And she said, let me talk to my group. And she said, okay, I've spoken to my group. we'll have to have a multidisciplinary meeting. And I said, okay, wonderful. At 34 to 35 weeks, we're going to have a multidisciplinary meeting with nursing and everybody, and we're going to make this mama's dream possible. Well, life happens. So mommy calls me on a Friday when she is 33 plus weeks and says, Dr. George, I just called my OB. I am in full-blown labor. Mind you, she's a multip. And I'm driving to the hospital, but she was in the middle of the island and we had made that conversation with Kona. So I said, how far are you from each? And she's like, well, I'm kind of in the middle. I actually did not know at the time that she was driving. I thought she was being driven. And she had actually two other kids in the car. So she was in full-blown labor, two other kids in the car, and she drove from the middle of Big Island to Kona. And when she got to Kona Hospital, everybody was relieved because they said, Dr. George, your geography was very off, but okay, learning, so pick up. So just to let you know, I did not know it's one road. I thought it, there was like diagonals, but nonetheless, mom got there safely. And now we had to figure out, we did not have a multidisciplinary team. Who do you think I forgot that was the most important in that plan before I made that plan? Nursing. So the nurses were like, oh, wait, hold up, hold up, hold up. I'm sorry. Are you going to have a dying baby here? We are not trained and we're not comfortable. Then the hospital had to be like, what are our bylaws? So that Friday night, I spent a lot of time on the phone with the CEO of Kona Hospital because apparently it's not a written bylaw, but an understood protocol was that any baby less than 35 weeks was automatically shipped to Kapulani. Any mom pregnant and in labor at less than 35 weeks was an automatic transfer. Mom had to sign some papers. It's a good thing that the nurses knew her because this was now her 9th baby that she had delivered at that hospital that she was going to be delivering. And nonetheless, long story short, I was able to fly over on Saturday morning and walk the nurses through on Saturday night when our precious Violet was born. Unfortunately, she was not born alive. She did not make it through the labor. But the mom is so grateful that she was able to meet her precious angel. She was able to attend Kamehameha Day 2 days after with her other angels. And now she has growing outside in a garden a sunflower, which we gave her as a bereavement package from March of Dimes. And it's growing so robustly. And after that, obviously, I met with Kona's hospital leadership to see how we could make this more streamlined and better and organized in the future with proper education. And we now call it, and where we expand to the outer islands, we will call it now Violet's Plan. So how do we make this happen? Next slide. We have partners in the community. And you should take a little photo of this slide because these are your people to be able to help your patients. Hugs will be able to help you get parents to pay for families other than mom and dad to come back and forth. And if they are private, because with Quest, they will pay for mom. But if it is that you have other family members who you want to come, they will pay for 2 others. And for private insurance, they would help. Navian is our hospice for our pediatric hospice on Oahu. They're very good and they're affiliated with Dr. Jensen, who is the physician who's one of ours. She's a hemong doc, a pediatric hematologist who coordinates with me, right? So I like to think palliative care is in the hospital, and then when they leave the hospital, we transition them to hospice care, which is just outpatient palliative care, for like the simplest way to say it. So these are community partners that help provide long-term support to families. Let Grace In is an organization started by a family, particularly a mama, she's a PICU mama, who lost her son Grayson to cancer. And every year she has a kind of, I don't know, what do you call a summer camp or workshop that families who are grieving can come to. Next slide, please. So let's talk about Cassie. She is one who we made Outer Island possible, but it was a little hybrid, so we'll see. See me for who I am. Cassie, a 14-year-old girl, is diagnosed with gonadoblastoma and angiosarcoma of the right ovary. She also has a rare genetic cancer, predisposition syndrome, which means her chances of long-term remission are really poor. Cassie is determined to fight. Next slide, please. While her mother is her legal decision maker, she also suffers some substance abuse disorder, the mom. So Cassie lives with her elderly aunt and her 2 younger sisters. She regularly attends a local church with her auntie. Cassie embarks on an intensive 10 months of treatment with chemotherapy, surgery to remove the tumor, her uterus, and both ovaries, and radiation therapy. Boy, she was a strong girl. She experiences many side effects and symptoms related to her treatment. The Pediatric Palliative Care team is consulted for symptom management, longitudinal assistance with social stressors, and to explore goals of care for Cassie and her family. Cassie is also enrolled in hospice with concurrent care on her home island. She developed a trusting relationship with one of her nurses. And I want to spend a little time talking about what concurrent care means. So when we have a palliative care patient that's identified in the hospital, we send that patient home with hospice. But if that patient that family still wants life-saving and life-prolonging measures, we send them home with something called concurrent care, where we can still do life-prolonging measures while they're in hospice. And I will tell you, the advantage of hospice is like having your own personal case manager, nurse, this whole team when you are at home to help you manage your medications, manage your appointments, have child life. There's child life part of that team too, to help Cassie's sisters understand what's going on. Sometimes as pediatricians, when a baby goes home, actually oftentimes as pediatricians, when a baby goes home on concurrent care, you will get some forms that you have to complete. And those forms have some peculiar statements in it saying, well, you are saying this child would only live, it doesn't have to be a baby, child would only live would die within the next 6 months. And sometimes it causes you a little bit of angst to sign that because none of us have a crystal ball. But what it is really, it's just saying that this child has a life-limiting illness and death can happen anytime within the next 6 months or not. And you're just signing so that the patient can continue to receive concurrent care and that specialized team rallying with them as they try to defeat whatever illness for however long. There's some kids who are in concurrent care now for years. And then there's some kids who graduate from concurrent care. So just something for pediatricians or physicians, any physician, to note when you get that paperwork. If it is that you feel any angst in signing, please reach out to myself, Jasmine Jensen, or any member of our team to be able to kind of walk you through it. Because illness, some patients will have the same disease and die within 6 months, and some patients will have the same disease and die 4 years later. We just can't explain why in medicine. Next slide, please. Cassie achieves remission. Amazing. The achievement is emotionally challenging, apparently, and her mother relapses into substance use around the same time. Sadly, Cassie relapses with widespread disease 5 months later. Her auntie is now her medical decision maker, but her auntie herself is diagnosed with early stages of dementia. Next slide, please. Cassie struggles as she's confronted by so much hardship, right? You think sometimes when you hear some of our patients' cases, you're like, why does bad things happen to good people? She acts out. She's a teenager. She's 14, and she becomes argumentative with her medical team. Cassie and her auntie decide to pursue additional intense therapies. More chemo, surgery, HIPEC, which is, I had to look this up because I deal with neonates. So it's intensified treatment. It's like heated treatment of chemo of cancer that's localized to the abdomen. She has more radiation. She experiences many complications. She requires an ostomy, urethral stents, and eventually a Foley catheter. Her symptom management becomes very complex. She also grows close to the hospital chaplain and others at Capilani Medical Center for Women and Children. Next slide, please. After a debilitating infection and long PICU stay, she asked to talk to the palliative care MD, someone she knows well. Next slide, please. I know I am dying. Please don't give up on me. Help me go home just one more time. She also explains that she cannot die at home because she doesn't want this to be her sister's final memory of her in the house they share. Next slide, please. With the help of Neighbor Island Hospice, and you may think that the hospice in Oahu is so good and the Neighbor Island hospices may not be as good. Well, I will tell you, we have visited them. They're amazing. And the nurse who befriended her, she is discharged with a plan to return in a week. 1 week becomes 2, then 3, then 4. Next slide, please. Cassie's hospice RN eventually calls her palliative care MD and says things are changing. Cassie returns to CAP. She has developed a GI bleed and recurrent bowel obstruction. Cassie and her auntie have discussed what to do when the time comes. Her auntie is struggling more with dementia symptoms and tells the team she will support Cassie's choices, whatever they may be. Cassie tells her team that she feels safe at the hospital. Next slide, please. I'm not sure how to do this part. I only know how to fight the cancer. The palliative care team helps Cassie to reframe her thoughts. What are we fighting for today? What are we hoping for today? Cassie dies peacefully and comfortably on the Wilcox unit with her auntie and trusted care team at her side. Bereavement needs were identified for Cassie's family as well as the staff. Next slide, please. Healing and moving forward. The Kubler-Ross grief cycle talks about 5 stages of grief. You have denial, anger, bargaining, depression, acceptance. Do you think that patients go through these cycles just as they are? So they go from denial to anger to bargaining to depression to acceptance? We wish, because then you'll be able to tell when you meet them and when you talk to them, even with our family members, right? If we've ever experienced a loss, we'll be able to say, okay, well, they had bargaining, so that means depression is coming soon, so I'll get prepared for depression. Unfortunately, life is not that easy. Patients, when they meet you, whether they are pregnant with a devastating fetal diagnosis, or they are a family with a 6-year-old who's just been diagnosed with leukemia. They could be at some point, at any stage of this grief cycle. They could be bargaining. I promise I'm going to go to church every single day, God, if it is that you heal my baby's, my child's body of this cancer. If it is that you make sure those doctors are wrong and that genetic test is wrong and this is not trisomy 18 and it was just something that was an April Fool's joke. Next slide, please. So at Capilani, we've extended our legacy making, which positively impacts the bereavement experience of families. But we're not just stopping at CAP. We have a grant and we're going to do education on all of the outer islands. And we just finished with Kauai Vets. And what we'll be giving is we want to expand this where patients, when they come to Oahu, they don't get the red carpet experience for bereavement care. And then when they're on an outer island or anywhere else, they don't. So we're trying to really expand. What do we offer? Well, we offer a memory box, which I think a lot of you have seen. But something new that we offer, which has taken so much traction at Capilani, we actually ran out and had to order like a huge shipment, is the teddy bear. What we do when a mom comes in, to avoid situations like Violet, where we didn't get to have any heartbeats, monitoring for any heartbeat to give that mama. When a mom comes in pregnant, we actually use the CFM. It's one of the loudest heartbeat monitors. And when a child is on Wilcox or Carter, we can take a Doppler or in the NICU and we record their heartbeat onto that circle heartbeat recorder. Heart-shaped recorder. And then we place that recorder into the teddy bear. And on that family's hardest day after the passing of their child, they can squeeze the left side of that teddy bear's chest and hear their child's heartbeat. We also realize that sometimes, especially in the NICU and the PICU, the machines that they're on make it really hard to hear the heartbeat properly. So now we're printing out the rhythm strip, that cardiac monitor strip, and we put it in a bottle and we give it to the parents. And it comes attached with a note that says, this is your baby's or your child's, name the child's heartbeat. We have the Now I Lay Me Down to Sleep, where these are the photographers that can come in and do personalized pictures with the family. I will tell you, sometimes families are like, no, we don't need pictures. Oh no, every family needs pictures. You could offer the family, let me take a few pictures and I can keep those pictures. And if it is that you want the pictures in a year or a week, we will have them here waiting for you. And what we can do is, because those pictures are raw, you can always reach out to me. I'm a medical affiliate for Now I Lay Me Down to Sleep, and I could upload it to their website and it could be touched up. And the parents can get really professional pictures. I will tell you that I've had a case where a family left their preemie in the NICU, went back to California, both mommy and daddy, because they were working. And then that preemie developed neck. And I called the family and said, we can try to keep baby as awake, as alive as possible. Are you able to come back to Hawaii? And they said, no, we cannot. So that day, everybody took turns holding that baby as he passed away. Do you believe? A week later, those parents called, where are our pictures? We want some pictures. So everybody wants pictures. We hold it for them until they're ready. We have changed the policy at Capilani and hopefully everywhere else we can change. When a baby has passed away, they can stay with the mother up to 24 hours, the deceased baby. Regardless of need for autopsy, they can stay with the family up to 24 hours in that caring cradle. And lastly, we do 3D molds. It's the one time that I get families to kind of forget all of the awfulness that's happening around them. And I engage the father to help me make a 3D mold. If you are a baker or you bake or you cook, you'll be good at this. I'm not a baker, so if I can do it, anybody can do it. And basically, it's just mixing the mold and you make a 3D hand mold and a foot mold. And we try to do 2 molds because not all the time they come out great. Next slide, please. And I encourage everybody, wherever you are, whether you're in an ER, and you've had a loss of an adult or a pediatric patient, wherever you are, I encourage everybody to do the pause. A Delphi methodology examining an end-of-life practice called the pause. What they found is that the pause poses minimal risk, has considerable benefits. And these benefits include increased perceived team cohesion, a moment for reflection, and a method by which to honor a deceased patient. The pause allows nurses to feel more present to meet the needs of the next patient they have to care for during their shift. So what a pause is after you've lost a patient in whatever setting, whether it be pediatric or adult, that anybody who came into contact with that patient, go to a separate place, bring everybody in, have 30 seconds to 1 minute of silence to honor the life that we've lost. And then open up the room for people to talk their truth, to speak how they feel. This could be led by a chaplain, by a social worker, by a physician. It is not where we're pointing fingers, oh, we could have done this differently. No, it's the one moment where we stop as healthcare providers and we take care for a minute of ourselves. We check in with each other. We make sure that we're doing okay and that we have some adaptive coping mechanism. For me, I don't know how adaptive it is, probably not the best, a little bit maladaptive. I go for McDonald's milkshake when I'm done. The problem is that, as you know, McDonald's doesn't always have a functional milkshake machine. Next slide, please. I invite everybody to do the annual memorial tree trimming. To come, it is held usually at the church right next to Capulani. And we are in our 35th year, and it's an opportunity to remember and recognize the losses of children in the most recent years and years prior. It features a family speaker who shares their story. And it's a community event with the symphony and musicians. And what happens is, what I thought when it said tree trimming, I'll be honest, I thought that we were like trimming the tree. But what it is that every family takes ornament, and it's held at Christmas time. And they go and they put that ornament on the tree. And as they're called up, they call the life of the child that has been lost. Next slide, please. Any questions? I know that was a lot. Sorry. I think what I want to leave with you guys are some things that will be good for your toolbox, your toolkit. Thank you, Alison. 1, try not to, before a patient passes, try not to use the words I'm sorry. I hear from Vital Talks when I did the Vital Talks, which we're going to start doing. And our goal is we've all become, the palliative care team MDs have all become now trained in Vital Talks. And we want to be able to have everybody have some experience with Vital Talks. So that's coming. It's on the horizon. But going back to our toolkit, try not to use the words I'm sorry before a patient has passed. What you can use is, what it says, it kind of pivots on us, right? It starts with I. We want when we're in the room with the patient, we want it to be about them. True empathy is getting into the hole with that patient and being in there with them. So you want to use statements like an I wish statement. I wish that things were different. And I worry that your child may not survive another treatment course. Notice I stressed on the word and. And we all know in our private lives, when you use but, if anybody uses but with you in a sentence, you have forgotten every single thing they said before but, and you only remember what they said after but. So we try to use and. Okay? So that's one thing for your toolkit. After a patient has passed, you can say, I am sorry. It's okay to cry. I think in med school, they're like, don't cry. Okay, well, we're human beings, we'll cry. Actually, to that family, it's a sign of true empathy. Only one thing when you cry, please don't have it that you're crying more than the family and they now have to comfort you. Okay? But you can use, but what families love is there's always something particular about that child. Like for Cassie, it seemed like she had a little bit of a, she was a feisty one. She was a fighter. So for her aunt, when you say, I'm sorry, you can draw on the fact that Cassie was such a fighter. She was such a spirited child, right? Other things to remember is don't forget to use your nurse statements. Sometimes I'm not big on, I talk a lot. Anybody who knows me, I'm a big talker, right? So it's interesting that I've gone into palliative care. It's quite interesting because that's a profession where you have to talk much less and listen more. And so what I do is I've had to develop how do I listen better? And sometimes often we listen to answer back immediately. No, no, no. We want to listen and truly listen. So for me, I start a countdown in my mind. So I know that even though I feel like it feels like a whole minute that I've been silent, I've only really been silent for hot 2 seconds. Okay. So exercising silence, reaching out to Jasmine and I at Capulani, you can call us anytime. And I can put my number in the chat to be able to help you guys with that concurrent care paperwork so that we make sure that all our patients get the absolute best care, regardless of where they are. All right, and I will stop there.
Thank you so much, Dr. George. I went ahead and started the questions. Sorry if we might go over a couple minutes.
Oh, I apologize.
No, it's okay.
I didn't see it up. I apologize. Oops.
Maybe while everyone is answering the questions, I can just invite anyone who has questions or comments to unmute yourself or put them in the chat. And if not, we are out of time, so we totally understand anyone who needs to leave. And we will look forward to seeing you next time. But I was wondering, those tips were so helpful, Kandie. And one thing that I'm thinking might be really hard for folks in the community is to know how to bring it up. If families don't know like about it, or it's just so anxiety provoking or whatever, can you give folks some tools, phrases that you think are effective for bringing it up in a direct but really compassionate and kind way so that we are being honest about what we're talking about, but also like being really gentle?
When you say, just to clarify a question, Maya, when you say bringing
Mhm.
it up, do you mean palliative care or just bringing
Yes.
palliative
Sorry,
care?
I meant palliative care, like when they have any kind of life-limiting diagnosis. And then after that, or if you want to go further, there are some questions in the chats too as well.
So
So
Maya,
feel free to prioritize those.
So Maya, that is an amazing question. And it is a really relevant question because everybody thinks neonatologists have it well. Like we are accustomed dealing with neonates and dying. So we do it really well. I will tell you that my neonatologists, they will come to me and say, okay, the parents declined palliative care. And I was like, what? Okay, no, we didn't ask it right. So the way to do it is to say to families, we have, it seems like you can name the emotion. It seems like you guys are dealing with a lot. We know that there's a whole team, a medical team. You have your oncologist involved. You have your PCP involved. But there's an extra team there's an additional team that could really support you through some of the social, the spiritual, and the decision-making processes. And that team is the palliative care team. And they're a small team, they're reachable, and they're going to be like family. And I recommend that we can let you meet this team and see if it is that they can help you through this really rough time of your life. So that's how
Thank
I
you. That's
phrase it.
perfect. Um,
Uh,
okay, there's lots of
question.
questions now in the chat. Can you see them, Kandie?
Yes. I'm
Okay.
trying to go back. Could you start from the top one? I'm trying to go
Yeah,
back.
the first one was from Kelly Hutchins, one of our PT Monk doctors. Is the teddy bear and heart available for any child who dies in the hospital or even with hospice at home?
Yes, Kelly. And we are making it. So before, we didn't have it available for everyone. Now I've been teaching bereavement across all of the nurses in the hospital, and actually the clinical ladder nurses have chosen this as their project. I deliver the teddy bears and the bereavement stuff to each unit. So there are some on each unit. Some units, it's a little bit obscure, but our educating of the nurses is going to be crucial in letting everyone know that it's available to everyone. Okay.
Thank
Next
you. And then
question.
Mary Nell said, there's no hospice facility on the Big Island. What are the options?
Actually, believe it or not, on Big Island, there are two hospices. So when I had to deal, there's one at Kona and there's one in North Hawaii. They're actually well staffed. So the problem was now because my geography is off, I was like, oh, maybe this patient is with Kona Hospice, but actually where she lived was North Hawaii Hospice. So they actually are there are hospices on each island. There's a hospice on each island, but two on Big Island.
Thank you. And then the last question that we have time for is there a Hawaiian practitioner for cultural considerations? And then lots of thank yous, of course. Great
So
presentation.
that is a great question because I will tell you, I do not claim to know. It's been a steep learning curve for me, and there's so much more to learn about the Hawaiian culture. We have been using our community partners to really help us to hone in on being culturally appropriate when we go have these goals of care discussions, right? And an example will be Chuki's families. Did you know that for Micronesian families, there is a hierarchy? I walked into a room with three women physicians. We walked in and we said, okay, there was a male in the bathroom, and we said, okay, let's just go in and let's go in and start the meeting, at least sit down. The woman would not budge. And I said, I'm so sorry, guys, you can go in and sit. Eventually, I guess, not knowing culturally, they go in, but they would not sit down. They stood. They stood until the men entered the room. And the men did not enter until the hierarchy of the family who was in the bathroom came out of the bathroom. So I'm learning as I go. Some days I do not get it right, but we are learning. So we're using our community partners to help us.
Thank you so much, Dr. George. I think the volume of questions and the effusive thanks is just testament to what important work you do. And thank you so much for putting these programs in place brick by brick for our kids and families who really need it. And thank you for a fantastic and really easily digestible and really human presentation. So we appreciate it, and we definitely look forward to inviting you back in the future.
Yes, and I just want to call out my palliative care team. I did not call him out. Dr. Jasmine Jensen is our outpatient. Inpatient is Elena Rose. It's spelled Alana, but it's pronounced Elena. She's our nurse practitioner, our social worker, Hope, and our chaplains, Utu, Bora, and Becky.
Thank you so much. Everyone, we look forward to seeing you in a couple of weeks. And Dr. George, we look forward to seeing you again soon too. Thank you,
Thank you,
everybody.
guys. Have a wonderful day.
Okay. Bye.